We are also running the hematopoietic stem cell transplant program for both malignant as well as benign disorders, including both autologous as well as allogenic hematopoietic transplants. A large bulk of our work also constitutes consultative hematology, where we have the pleasure of interacting with the various departments in the institute, and we are happy to help out with issues with cytopenias, coagulation issues, ICU consults, and many times surgical clearances. We're happy to state that the OPD and the IPD workload has shown a steady increase over the last 3 years, and we hope that this trend continues well into the future. A little data about our hematopoietic stem cell transplant program. A total of 91 transplants have been done so far, beginning in the year 2020, and I'm happy to state that we've been gradually picking up pace, and we are on course to do maybe 50 or more transplants this year, and with a target to reach the magic 3 figure in the coming few months. With this brief introduction, I would like to begin our case for the clinical combined rounds. It's a case of a 2-year-old boy with recurrent fever and gum swelling, and I hope that with this presentation we will have a lot of fruitful interaction and a learning for everyone present here. I would like to call the first presenter, Dr. Vaishali Sharai, DM resident from the Department of Clinical Hematology, to start the case.
Thank you, sir. A very good morning to respected professors, seniors, and my colleagues. I would be presenting a case of a 2-year-old boy. Informant, being the mother, informed that the boy had fever since 2 months, gum swelling also since 2 months, and bleeding from gums since last 2 days. The boy was apparently alright 2 months back when he developed fever, which was high grade, intermittent, not associated with chills and rigor. It had no aggravating factors, but it was relieved on taking antipyretics. There was no history of cough, sore throat, difficulty in breathing and swallowing. There was no history of vomiting, skin rash, abdominal pain, night sweats, or weight loss. The gum swelling and bleeding was present in both the upper and lower gums, persistent, painful. It also bled on trauma like brushing the teeth and consuming hard foods. The symptoms were so much so that he was afraid to eat, and they were associated with a foul smell. There was also no history of bleeding from any other side, no history of bruising, any chronic drug intake, no history of blood transfusion, contact with tuberculosis patient, joint pain, skin rash, oral ulcers. There was no history of weakness or pain in the limbs, chest pain, or crying while passing the urine. Coming to the past history, the patient had an episode of gastroenteritis at 1 month, another gastroenteritis at 3 months which required IV antibiotics, another episode of pneumonia at 7 months which also required IV antibiotics, gastroenteritis 9 months requiring IV antibiotics, another pneumonia at 11 months requiring IV antibiotics, cough cold at 1.2 years which required oral antibiotics, another episode of pneumonia at 1.5 years requiring IV antibiotics, and he had OPD visits about once a month for some or the other illness. So in total, about 10 episodes of infection and 4 hospital admissions since 1 month of age. Family history: he was born from a non-consanguineous marriage. He had a history of 3 sibling deaths, 2 of which males who died of pneumonia at 9 and 8 months of age, an 11 days old female who died of anemia and meconium stained liquor. There was no history of tuberculosis in the family. Antenatal history: the mother was a booked case, the viral markers were negative, and antenatal period was uneventful. He was born from an institutional vaginal delivery full term with a birth weight of 2.5 kgs. He passed meconium at birth, and there was no history of NICU admission. Immunization history was complete for age. Immunization was complete for age, that is till 4 months. After that, no further vaccines were given due to episodes of recurrent fever. Dietary history showed a calorie intake of 500 kilocal per day. A normal intake would be 800 for this child. Protein intake of 8 grams. So he had a calorie deficit of 300 kilocal per day and a protein deficit of 2 gram per day. All gross motor, fine motor, language and social milestones were achieved as per age. He belonged to a upper lower social class as per modified Swami scale. So a 2-year-old boy with fever and gum swelling since 2 months, gum bleeding since 2 days, a history of recurrent infections and hospitalizations, history of 3 sibling deaths in infancy, and a decreased calorie and protein intake. What could be the possibilities?
Pediatricians, anybody wants to just list a few?
Yes, sir.
So residents, can you come up with anything else? Carry on, Vaishali.
BB was 90 by 50 mmHg taken in left arm supine position. Heart rate was 140, normovolumic, regular. Temperature 104 degree Fahrenheit. Saturation 99% at room air with a respiratory rate of 18. The child was conscious oriented. There was subcentimetric bilateral cervical lymph nodes present which were firm and the overlying skin was normal. Gum bleeding and hypertrophy was present. There was no pallor, icterus, cyanosis or any other findings. Head to toe examination was also unremarkable. So he had a weight of 9.3 kgs and the expected weight for his age would be 12. A length of 80 centimeters and expected would be 85. So he lied at the 3rd percentile as per the WHO child growth standard chart for weight for age and height for age. Systemic examination, periabdominal examination was normal. All other systemic examinations were also normal. Since the child had gum swelling, I would now like to invite Dr. Simran from Department of Pediatric Dentistry to take this case further.
Good morning. I am Dr. Simran Vangani from the Department of Pediatric Dentistry. So the patient was referred to the Department of Hematology to our department with the chief complaint of gum swelling for 2 months and gum bleeding for 2 days. On inquiring, the parents revealed that the patient used to brush his teeth very occasionally. The aggravating factors for bleeding were brushing and chewing on hard foods. There were no relieving factors reported and it was the child's first dental visit. On soft tissue examination, we noted that there were generalized gum hypertrophy present. The gingiva was swollen, glazed, spongy tissue and deep red in appearance. It was tender on touching and brushing. Bleeding on probing was present. The gingival margins were irregular and there was heavy plaque accumulation. Also, there was presence of heavy supragingival calculus. The tongue, labial mucosa, buccal mucosa, hard and soft palate showed no abnormality. On hard tissue examination, we noted that complete primary dentition was present and no caries were detected. So based on the examination, we clinically diagnosed it as chronic generalized gingivitis. So since this is a 2-year-old child, the most probable etiological factors that we could suspect were due to poor oral hygiene, malnutrition, scurvy, leukemia, or due to immune deficiencies. So the management which we suggested were, the parents were instructed to brush the child's teeth twice daily using a finger toothbrush. As you can see in this image, this is a finger toothbrush, and use a smear-sized amount of fluoridated toothpaste. Also, in antimicrobial therapy, the parents were asked to apply a cotton swab dipped in chlorhexidine gluconate 0.12% gel and apply on the affected areas. Also, if the child has the ability to swish and rinse the mouthwash, they can also do warm saline rinses. Lastly, dietary modifications were recommended, like the child was asked to consume fibrous fruits, vitamin C rich fruits and vegetables that would increase the salivary flow rate and hence increase the cleansing action. Also, they were asked to avoid sugary snacks and drinks to prevent the occurrence of early childhood caries in the child and have adequate hydration. After that, we referred the patient back to the Department of Hematology and asked them to come back after the systemic disease have been optimized. Now I would like to hand it over to Dr. Vaishali for the further presentation. Thank you.
So a 2-year-old boy with fever and gingivitis since 2 months, a past history of recurrent infections, history of 3 sibling deaths in infancy, who is malnourished, and there is no significant lymphadenopathy and hepatosplenomegaly. What could be the differential diagnosis?
So can the residents come up with some other bright diagnosis? सामने लिस्ट है आपके. चलो carry on please.
So, in the nutritional causes, it could be protein energy malnutrition and associated with scurvy. Infective causes could be HIV, tuberculosis, and fungal infections. In hematological causes, we thought of inherited bone marrow failure syndromes, acute myeloid leukemia, pediatric myelodysplastic syndrome. In inherited causes, it could be primary immunodeficiency disorders, cystic fibrosis, and primary ciliary dyskinesia. Hemogram showed a microcytic hypochromic anemia and a normal TLC. However, a reversal in neutrophil lymphocyte ratio was seen with a neutrophil percentage of 5 and lymphocyte percentage of 85. PBF also showed microcytic hypochromic RBCs. TLC was within normal limits. DLC was neutrophil 5%, lymphocytes 85%. Platelets were normal, no parasites seen, with an impression of neutropenia and a reticulocyte count of 1%. Iron indices showed a low serum ferritin and iron level. LFT with serum albumin and coagulation profile was normal. Renal function tests and serum electrolytes were normal. Chest X-ray was also normal. ESR was 20 and CRP was 12. Viral markers were non-reactive. ANA by IFA was also negative. So, a 2-year-old boy with fever and gingivitis since 2 months and a history of recurrent infections requiring hospitalizations as well. History of 3 sibling deaths in infancy, who is malnourished. He also has iron deficiency anemia with neutropenia. What could be the difference? Sir, those were non-significant as they were subcentimetric and they were sir submandibular. So, since HIV came negative and chest X-ray was normal, HIV, tuberculosis and fungal pneumonias are unlikely. I would now like to ask the house that what other investigations would you like to order for this child or request for this child? For the evaluation of severe neutropenia, bone marrow aspiration and biopsy was done under strict asepsis with sedation. So, samples were sent for bone marrow aspiration, bone marrow biopsy, karyotyping, and some samples were preserved. So, now I would like to invite Dr. Kusha to tell us about the findings of bone marrow.
Thank you, Dr. Vaishali. Good morning, senior faculty members and colleagues. I'll be discussing the hematological aspects of this case. So, peripheral blood smear examination was done for this patient, and which revealed microcytic hypochromic anemia, which means that the size of the RBCs was smaller than the nucleus of a small mature lymphocyte, as we can see in the first image. There was a reversal of the neutrophil to lymphocyte ratio, and there was predominance of lymphocytes seen, all of which showed normal morphology. Occasional neutrophils were also seen. So, a final impression of microcytic hypochromic blood picture with neutropenia was given. There were no atypical cells or blasts or hemoparasites seen. We proceeded further with the bone marrow studies. So, the bone marrow aspirate smears were cellular for age. The erythroid series showed normal maturation. The myeloid series was suppressed, and occasional metamyelocytes were seen as pointed by the arrow. The lymphoid series was increased with normal morphology. The megakaryocytes were adequate as pointed in the image. There were no atypical cells, blasts or granulomas seen. So the impression given was cellular aspirate with myeloid suppression and adequate megakaryocytes. The findings on the bone marrow aspirate was confirmed on the bone marrow biopsy. The left-hand side image is a low-power view of the H&E stained section of the bone marrow biopsy, which shows cellular marrow. There were no lymphoid aggregates, granuloma or fibrosis noted. A higher magnification of the same shows that the marrow spaces show increased lymphoid cells which had normal morphology. There was suppression of the myeloid lineage. Erythroid lineage was normal with normal maturation. Megakaryocytes were also adequate. There were no granulomas seen or no atypical cells seen. So, on the bone marrow aspirate and biopsy, the final impression given was cellular bone marrow aspirate with myeloid suppression and adequate megakaryocytes. Now, I would like to invite Dr. Vaishali to proceed further.
Karyotyping was also normal, that is male phenotype, that is 46XY. So what would be the differential diagnosis now? So since marrow did not show any atypical cells, there were also no dysplastic cells seen, and cellularity was normal. Inherited bone marrow failure syndrome, acute myeloid leukemia, and pediatric myelodysplastic syndrome become less likely. Our provisional diagnosis now would be a primary immunodeficiency disorder with malnutrition, with iron deficiency anemia and neutropenia, along with generalized gingivitis. To take this case further, I would now like to invite Dr. Omkar.
Thank you, Dr. Vaishali. Good morning, respected teachers, seniors, and colleagues. Myself, Dr. Omkar Choudhari. I am second DM resident in Clinical Hematology. I'll be taking this discussion further. So we have a 2-year-old boy with repeated infections since 1 month of age and family history of death of 3 siblings in infancy. So these red flag signs remind us made us suspect about the primary immunodeficiency disorders or PIDs. Many PIDs present as routine infections and may go undetected, undiagnosed. Jeffrey Model Foundation has given 10 warning signs of primary immunodeficiency, and our patient had 4 out of it. So whenever these signs are present, one should suspect that it could be a primary immunodeficiency disorder. PIDs are a heterogeneous group of disorders characterized by low or absent function of one or more component of the immune system, where adaptive immunity, innate immunity, or there will be combined immunity defect. So to certify further whether it is cellular immunity affected or humoral immunity affected, we requested for serum immunoglobulin levels and lymphocyte subset analysis. Serum immunoglobulins were done, and they showed IgG was low, Ig was low with a high IgM. This characteristic profile was seen in hyper IgM syndrome. Further, lymphocyte subset analysis was done. We showed normal absolute counts of T cell, B cell, and NK cells with a normal CD4 to CD8 ratio. So we have now a 2-year-old boy with low IgG, low IgA, and with high IgM, with normal subset analysis of T cell, B cell, and NK cells, pointing towards the diagnosis of hyper IgM syndrome. To confirm this, we requested CD40 ligand flow cytometry and mutation analysis. The flow cytometry analysis showed markedly reduced expression of CD40 ligand on activated T cells, which is consistent with the diagnosis of hyper IgM syndrome. We are thankful to Department of Clinical Hematology, PGI Chandigarh, for conducting this test on our request. Further, confirming further with NGS, NGS showed CD40 ligand gene mutation suggestive of X-linked hyper IgM syndrome. So final diagnosis is X-linked hyper IgM syndrome with malnutrition, with iron deficiency anemia and neutropenia, with gingivitis. I'm going to speak about hyper syndrome now. The prevalence is very rare. It is 2 cases per million population. It is X-linked recessive inheritance, and some cases are autosomal recessive as well. Now I'm going to speak about the pathogenesis of hyper syndrome. Whenever an antigen enters into the body, it is first processed by the antigen presenting cell and then processed to T cell for initiating an adaptive immune response. To initiate an adaptive immune response, CD40 ligand, CD40 binding is a prerequisite. So when there is a gene mutation, there is no binding of CD40 ligand and CD40. So which is the first step in the B cell stimulation for class switching, recombination and somatic hypermutation. So since there is no interaction, so there is a reduced formation of IgA, IgG. So as the management is concerned, there are supportive measures and definitive measures. Supportive measures are with treatment and prophylaxis of infections, nutritional buildup, and definitive measures include allogeneic hematopoietic stem cell transplant. So when the patient is diagnosed, we start giving him supportive care till definitive treatment is achieved, done. And after starting antimicrobial prophylaxis and immunoglobulin replacement therapy, patient improved, his clinical condition improved, his infectious episodes decreased, and patient's parents were advised for genetic counseling. The definitive treatment for this hyper IgM syndrome is allogeneic bone marrow transplant. To move with the hematopoietic stem cell transplant, the first step is HLA typing. Since patient had no siblings, so HLA typing with parents was done. Fortunately, he had 10 by 10 HLA match with the mother and half match with the father. In pre-transplant evolution, we found that mother is the carrier of the gene mutation. Since it is X-linked recessive disease and mother is phenotypically normal, we took the patient as a donor. We took the mother as a donor. The conditioning regimen which we give for the patient is thiotepa, fludarabine, thiosulfan and rapid ATG. The conditioning regimen is given pre-transplant for myeloablation and immunosuppression. Myeloablation is knocking off the recipient's bone marrow. Bone marrow harvest was taken from the mother and transplant was done on day 0. After conditioning regime, stem cell infusion was given on day 0 as shown in the image. Day 0 is the day of transplant, sir. Day of infusion plan. In this case, yes, sir. In this case, we have to, yes, sir. Post-transplant, patient was apparently well till 4 days. On day +5, patient had cyclosporine-induced hypertension and hypomagnesemia, which was treated with dual antihypertensive and IV magnesium. On day +10, patient had febrile leukopenia, which was managed with IV antibiotics. And meanwhile, it was 2.5 mg, sir. mg, OD. So it is given with consultation with the cardiologist.
Is it alright? 2.5 million, 2 million, 9
0.1 से 0.5 initially effectively I think BP control था तो फिर हम कम नहीं 2.5
Neutrophil engraftment was achieved on day +19. Neutrophil engraftment is defined as ANC more than 500 microliter on 3 consecutive days. Platelet engraftment was achieved on day 21. Platelet engraftment is defined as platelet counts more than 20,000 without transfusion on 3 consecutive days. On day +28, chimerism was sent, which was 100% donor cell. Chimerism means percentage of donor's hematopoiesis in the recipient. On day +29, patient had diarrhea, suspecting it as a graft versus host disease. Endoscopy was done and biopsy was done, which showed confirmed the diagnosis of GVHD and treated with injectable steroids. On day +40 to +60, patient had hypertension, hypomagnesemia and erythema, probably due to cyclosporine, which was managed with symptomatic treatment. IVIG prophylaxis monthly was continued and steroid was tapered. On day plus 90, chimerism was again sent, which was 100%, which showed 100% donor cells.
I mean, having actually 100% match, you have so many reactions after that also.
Yes, sir. The graph was taken from the
Standard post bone marrow transplant. Every single patient will have neutropenic infection, sometimes very severe, and majority of them will have some degree of graft versus host disease.
Actually, genes that we are testing are only the major histocompatibility genes, but there are several other groups of genes which are not tested for, but they also are responsible for the self versus non-self recognition. So even with a full match, we are sure that the major reaction from the donor cells towards the recipient is not going to happen, but some amount of GVHD is expected. And even with a full match, sometimes even we see grade 4 life-threatening GVHD, and we even lose patients to that. So the immunology, like it runs in several layers. We are only able to test like the topmost and the most significant one, but there are several layers to it, which include some parts of the innate immunity as well, which we are not able to test, and which ultimately come up with these issues.
You are not able to test here only or anywhere?
Anywhere. So the minor antigens are not exactly matched for, and having a completely identical set of major as well as minor antigens would only be seen in identical twins. Otherwise, no two individuals would have the complete identical set.
in post-transplant day 90 plus 92 day plus 180, patient was active, playful. No, there was no evidence of infection. IVI just stopped at 3 months. Patient had weight gain of 4 kgs. Serum cyclosporin was continued and steroid were tapered off, while the antimicrobial prophylaxis was continued.
What about hypertension?
So that it was continued, sir. Yes, antihypertensive were continued, sir. This is patient's current hemoglobin levels. Patient is presently day plus 185, and recent investigations day plus 180 showed normal IgG, IgA, and IgM, as shown in the table. Now I would like to invite Dr. Priyanka Soni ma'am to take this discussion further.
Cyclosporin must be required for how long? Lifelong or
No, sir. For 1 year, for a period of 1 year, sir. That will happen.
when do you stop it?
For 1 year, sir. After 1 year.
At 1 year, what parameters must be fulfilled before we can stop?
So we check the chimerism regularly, and we adjust the dose of cyclosporin according to chimerism, firstly, and the presenting issues the patient is recovered from the clinical aspect, and also the infectious profile of the patient.
So
How is
GVHD should not be there.
GVHD.
As well. If the patient is having GVHD, we would like to continue the immunosuppression for longer. What happens is T cells, once they go inside the body and they are continuously exposed to the recipient's antigen, over a period of time, a T cell energetic response starts developing. So overstimulation by an antigen would lead to loss of response by the T cells after a certain point of time. That is how our own T cells become desensitized to our own antigens when they are exposed to our antigens in the thymus. And in hematopoietic transplants, over a period of 1 year, 6 months to 1 year, that kind of energy is achieved. So even without immunosuppression, with a donor hematopoiesis going on in the body, the patient can lead a very normal life without any issues. But that usually takes 6 months to 1 year. In benign transplants, we would prefer to continue for longer, preferably 1 year, unless there are toxicities which are stopping.
Thank you, Dr. Omkar. Good morning, respected Chairperson, Emeritus, dignitaries, faculty, and students. So, immunodeficiency disorders are a rare group of disorders, and so far, almost 430 disorders have been recognized by International Union of Immunological Society. So, X-linked hyper-IgM syndrome presents in 1 million males, and it comprises 2.9% of all primary immunodeficiency disorders. It usually presents the main deficiency, as told earlier, is binding of formation of CD40 ligand, due to which is present on helper T cells. Now it is unable to bind to B cells, and where the actual class switching occurs. So the antibodies are not formed, and it is also involved in T cell activation. So it is actually a type of a combined immunodeficiency, combined humoral and cellular immunodeficiency. Usually the kids present at the age of 6 to 18 months with recurrent respiratory tract infections, diarrhea and failure to thrive. There could be other manifestations like autoimmune manifestations as well as malignancies. Once the disease is diagnosed, the most effective therapeutic approach is immunoglobulin replacement, which should be started in a timely fashion, which will reduce the frequency as well as the severity of infections. But it will not reduce the long-term complications like sclerosing cholangitis and other manifestations of the disease. So, so the two were male and they died at the age of 7 months. So probably they could be also the affected males. And one was a female child which expired due to at the age of 11 days because of meconium stain liquor. So it might be yes.
It could be autosomal dominant. No?
So इसमें genetically we have
तीन children death, possible cause देख रहे हैं, जैसे X लिंग में 2 बच्चों को समझ में आ गया, मतलब तीसरा फीमेल है, तो उसका autosomal
autosomal recessive.
Homozygous हो सकता है, मतलब both alleles could be mutated, then only the carrier will come.
So in this we've got confirmed there are hyper IgM syndrome which are autosomal recessive also, which have yes sir. So there are other subtypes of hyper IgM syndrome which are autosomal recessive also. But in this particular case, we have done the mutation and we have found that it is X-linked recessive. So probably the death of the female could have been because of other acquired causes. That is what we are suspecting.
As an obstetrician, I know if the child has or infant has swollen.
Yes sir. They develop respiratory distress.
Then they will either survive or they will die.
Yes sir.
The girl
11 days.
11 days per doctor.
Yes. So therefore, a definitive treatment, that is hematopoietic cell transplant, should be planned as soon as the diagnosis is made. So in the literature review, we found that there are 2 case reports, one from Wadia Hospital and one from PGI Chandigarh in 2015 and 2023. And globally, 40 cases have been reported, and we are going to write the 3rd case report from India. In a recent meta-analysis, which is published in year 2024, the overall outcome at 10 years has been found to be 78%. And this patients who did not undergo transplant, the mortality was about 25%, and only 20% patient could survive beyond the age of 25 years. And the major causes of mortality have been infections as well as sclerosing cholangitis and malignancies. So the overall outcome over the last 40 years where the transplants have been performed is approximately 73%. So we are equipped to perform hematopoietic stem cell transplant not only for malignant disorders but also for benign hematological disorders. So we have done 13 transplants in benign hematological disorders, out of which 4 transplants have been done for rare inherited diseases. And we are thankful that the survival as of now after 1.5 years is 100%. So we are thankful to our BMT team, our residents and our faculty for providing the support, and management for providing the support in a form of good hematopoietic transplant cell unit. So to conclude, I would like to say that we have selected this case because of the rarity of the case and because we have done the complete workup as well as the treatment, and finding a full match donor in parents, the chances is only 2%, and for this kid was fortunate enough that the mother was a donor. So recurrent infections in children, whenever they present, we should suspect immunodeficiency disorders. High index of suspicion should be made and it should not be missed as a routine case. It is important that a systematic multidisciplinary approach should be followed and timely accurate diagnosis should be done. Had it been that the diagnosis has been done in the previous 2 kids also, probably the earlier siblings of this child could have been saved. As soon as the diagnosis is made, it is important that we start the supportive care and we start with IVIG prophylaxis, antibiotics and antifungals. Hematopoietic stem cell transplant is the only curative treatment for primary immunodeficiency disorders. So all PIDs are not fatal. Thank you. So we are thankful to the management of MGUMST for providing us the opportunity to present our case, Department of Pediatric and Preventive Dentistry, Department of Oncopathology, CCR Review Committee, especially to Dr. Jaiswal and Dr. Rupesh Masan for providing us the inputs, nursing staff, patient and family, and also to the Department of PGI Chandigarh for providing us an academic collaboration. Thank you.